Hello everyone. In today's video, we will be discussing syndromic craniosynostosis. We have to remember that almost all the craniosynostosis are sporadic, autosomal dominant. Most common suture involved is the coronal suture, and there is midfacial hypoplasia. Due to the coronal suture involvement, there is hypertelorism, and due to midfacial hypoplasia, there is exorbitism. We will discuss here Apert Syndrome, Crouzen Syndrome, Pfeiffer Syndrome, Chotzen Syndrome, Maenke Syndrome, Carpenter Syndrome, Jackson-Weiss Syndrome, Craniofrontonasal Dysplasia, ERF Related Craniosynostosis, and TCF Related Craniosynostosis. So let's begin. Our first topic will be the Apert Syndrome. Apert Syndrome is also known as Acrocephalosyndactyly Type 1. There are many of the syndactylies, and this is the type 1 acrocephalosyndactyly. Here there is FGFR2 gene mutation, and there is bilateral coronal craniosynostosis. So therefore, if there is bilateral coronal suture involved, there will be brachycephaly. Breadth of the skull will be increased, and it can also be associated with clover-shaped skull. Because of the brachycephaly, there will be mild hypertelorism. There will be midfacial hypoplasia, and because of the hypoplasia there will be exorbitism. Orbital content will be coming out of the orbits. There will be associated high arch palate, anterior open bite, parrot beak nose, simple syndactyly of the feet, segmentation of the lateral four toenails, and there will be low IQ. The complex symmetric syndactyly can be of three types. The first type will be the spade type, second type will be the spoon type, and the third type will be the rosebud or hoof type. In the images we can see there is hypertelorism, there is terricephaly, we can also see there is frontal bossing in this image. Now coming to the Crouzen Syndrome. Crouzen Syndrome is also known as craniofacial dysostosis. It is associated with increased paternal age. Here is also there is FGFR2 mutation. Here similar to Apert Syndrome, there is bilateral coronal suture fusion. Therefore, there is brachycephaly. Brachycephaly causes mild hypertelorism. There is associated midfacial hypoplasia leading to exorbitism, but here extremities are normal. This point differentiate Crouzen syndrome apart from Apert syndrome. Clinically we can differentiate. There is a variant of Crouzen syndrome where Crouzen syndrome is associated with acanthosis nigricans. Here there is FGFR3 mutation. It is associated with choanal stenosis, hydrocephalus, and skin hypertrophy on the flexor aspect. Now we have to discuss about the ERF related craniosynostosis. It is very similar to the Crouzen syndrome, but there is late onset multi or sagittal suture craniosynostosis. Because of this late onset, the symptoms are very mild midfacial hypoplasia. Because there is very mild midfacial hypoplasia, the class 1 occlusion of the teeth are maintained. As other points are exorbitism, hypertelorism, nasal dysmorphology, and Chiari malformation. Here we can see that in ERF related craniosynostosis there is pansynostosis. All the sutures are fused. Now coming to the Pfeiffer syndrome. Pfeiffer syndrome is also known as Acrocephalosyndactyly Type 5. But there are three variants of the Pfeiffer syndrome. Type 1 variant is most common and has good prognosis. In type 1 variant, there is bilateral coronal fusion. There is bilateral coronal fusion leading to brachycephaly and terricephaly. Brachycephaly. There is midfacial hypoplasia leading to exorbitism. What are the characteristic points differentiating it from Apert and Crouzen syndrome is that there is radially deviated thumb and medially deviated toes, and there is simple syndactyly. IQ is normal. Coming to the type 2 of the Pfeiffer syndrome, there is pansynostosis leading to clover leaf skull. There is also associated elbow ankylosis, not these things. The IQ is low. There is also type 3 variant where instead of this pansynostosis there is variable craniosynostosis. Therefore, clover leaf skull is not present here. There is short anterior cranial base. Elbow ankylosis and low IQ are similar to type 2. Both type 2 and type 3 have short tracheal cartilaginous sleeve. Therefore, there is need of permanent tracheostomy. The prognosis is poor compared to the type 1 Pfeiffer syndrome. Here we can see the clover leaf skull defect in the Pfeiffer type 2. There is deviation of thumb medially in the Pfeiffer type 1 syndrome. Now coming to the Chotzen syndrome. In Chotzen syndrome, it is also known as Acrocephalosyndactyly Type 3. There is twist 1 gene mutation. Here only one suture is involved, either it is coronal, lambdoid or metopic. Because only one suture is involved, there is very mild clinical presentation. Therefore, diagnosis is sometimes difficult. Asymmetry of face is more common than hypoplasia, and ptosis is more common than exorbitism. Here in the front view we can see the face is appearing normal, but in the top view we can see that there is elevation and recession of the right brow, best seen in the top down view. There is right coronal unicoronal craniosynostosis. Besides, there is one other characteristic finding also known as low frontal hairline, which is very much prominent. Besides that, there is prominent helical crux in the low set ears. Besides, similar to the Chotzen syndrome, there is TCF12 related craniosynostosis. Here also there is twist 1 gene mutation, but the penetrance is very variable and often involve coronal sutures, either unilateral, bilateral. IQ is normal and prognosis is good. It is a very rare condition. Now coming to the Maenke syndrome. Maenke syndrome is the most common syndromic craniosynostosis. It is due to FGFR3 mutation. It is also associated with increased paternal age. The penetration is variable. There is unilateral or bilateral coronal. Therefore, there is brachycephaly and there is frontal bossing. Sometimes there can also be macrocephaly in absence of premature suture fusion. Characteristic points in this condition is the carpal and tarsal bone fusion and thimble-shaped middle phalanx. So here we can see the tarsal bone fusion and here carpal bone fusion. There is also middle phalanx thimble shaped. There is associated sensory neural hearing loss, ptosis and IQ is low. Coming to the Carpenter syndrome. Carpenter syndrome is also known as Acrocephalosynostosis type 2. It is only one of the few autosomal recessive condition due to RAP23 gene mutation. It is rare disease. Here there is craniosynostosis of sagittal or lambdoid suture and there is late coronal suture fusion. Therefore, there is characteristic shape of tetracephaly. There is characteristically polydactyly of the first and second toes, polydactyly. There is simple syndactyly of the feet, IQ is low. There is short hand, brachydactyly. Middle phalanx, there is agenesis. This condition is also associated with obesity. We can remember this Carpenter syndrome by Carpenter cutting his middle phalanx. Now coming to the Jackson-Weiss syndrome. Jackson-Weiss syndrome is due to FGFR1 gene mutation. There is mild craniosynostosis with midfacial hypoplasia. IQ is normal. Characteristic finding is widening and medial deviation of the great toe. There is short metatarsal, broad proximal phalanx, and simple syndactyly of second and third toe. There is also fusion of the metatarsal bones. So Michael Jackson, we have to look for the feet. Now coming to the craniofrontonasal dysplasia. Craniofrontonasal dysplasia, there is EFNB1 gene mutation. It is X-linked dominant condition. Therefore, the condition is more severe in females. There is coronal craniosynostosis. Therefore, there is hypertelorism. Here, hypertelorism is very severe. There sometimes this condition is also associated with bifid nose, bifid nasal tip, and there can also be cleft lip and cleft palate. There is longitudinal ridging or splitting of nails, cervical waving, and clinodactyly. Here we can see there is medial deviation and medial deviation of fingers and lateral deviation of toes. There is also splitting of the nails. Thank you.